Hello friends, let us now discuss the topic of oropharynx. So oropharynx is the middle part of the pharynx and it lies behind the oral cavity. So we know that this oropharynx, it extends from the hard palate to the hyoid bone, right? So we discussed that earlier. Now let us look at this oropharynx. What all is present in the oropharynx? So we can see in this photograph, we have palatine tonsils. So this is a pair of tonsils, one on each side. So we have these lymphoid tissues known as palatine tonsils. What else do we have? You see these tonsils, they lie in a tonsillar fossa. Okay, the anterior wall of this fossa is formed by a muscle known as palatoglossus. Okay, the posterior wall, the posterior tonsillar pillar is formed by palatopharyngeus. All right, so there are two walls or two pillars of the tonsillar fossa. The anterior tonsillar pillar is formed by palatoglossus and the posterior tonsillar pillar is formed by palatopharyngeus. Remember, this is the same palatopharyngeus muscle which will go and it forms the passavant's ridge, right? Okay, now what else can we see? We can see over here the posterior 1/3 of the tongue, that is also known as base of tongue. So of course that forms the part of the oropharynx. Then we also have the epiglottis. So yes, the epiglottis, it comes from the larynx. So above the level of hyoid bone, this epiglottis, it forms a part of oropharynx. Now between the base of the tongue and the epiglottis, there is a space. This space is known as vallicula. Okay, this space is known as vallicula. Remember, the epiglottis is attached to the tongue by a mucosal fold in the midline. So in the midline over here, the epiglottis is attached to the tongue base. Now this is known as glossoepiglottic fold. Now this is just a mucosal fold and it divides the vallicula into two parts, the right side and the left side. Okay, so the vallicula is divided into two parts, right and left, but this vallicula is a space between the epiglottis and the base of tongue. All right, now what can we more see? We can see that in the posterior 1/3 of the tongue, we have small lymphoid tissues. So you see all these small lymphoid tissues, they are visible to you, and these small lymphoid tissues, they are known as lingual tonsils. Okay, so they lie in the posterior 1/3 of tongue at the base of tongue, so they are known as lingual tonsils. All right, now just remember what we studied in the nasopharynx and what we have just studied in the oropharynx. What do we know? We know that in the midline, in the nasopharynx posterior superior wall, we have a lymphoid tissue known as adenoids. Now on the sides of adenoids, on the lateral sides, around the eustachian tube, we have lymphoid tissue, we call them as tubal tonsils. Okay, then in the oropharynx, we have a pair of lymphoid tissue, one on each side, we call them as palatine tonsils. And then in the base of tongue, we have another lymphoid tissue known as lingual tonsils. Together, these lymphoid tissues, they form a ring. This ring is known as Waldear's ring. This ring, Waldear's ring, is the first line of defense against ingested or inhaled bacteria and viruses. So whatever tries to go in, these lymphoid tissue, they react and they try to stop it from getting into our body. So this is the first line of defense, the Waldear's ring, formed by the adenoids, tubal tonsils, palatine tonsils, lingual tonsils. Okay, right, let's go ahead and let's look at these tonsils. So they are the most important structure in the oropharynx, palatine tonsils. They are one on each side. Now how are these tonsils different from other lymphoid tissues in the pharynx such as adenoids? How are they different? They are different because unlike the adenoids, they are covered by a fibrous capsule. Okay, so remember adenoids, lingual tonsils, they are not covered by any capsule, but the palatine tonsils, they are covered by a fibrous capsule. This fibrous capsule on the medial aspect of the tonsil, it goes inside the lymphoid tissue. So as you can see over here, it is going inside the lymphoid tissue and it form crypts. Alright, so these crypts, what you can see, they can be primary crypts and then they divide. As you can see over here, they have divided, and when they divide, they form secondary crypts. Sometimes they can even form tertiary crypts. The largest crypt is known as crypta magna. Right? The largest crypt is known as crypta magna, and that denotes the presence of second pharyngeal pouch. Okay, so that denotes the presence of second pharyngeal pouch in embryonic life. Crypta magna, the largest crypt, lies just near the superior pole. All right, now what else do we have? Now we know from our earlier knowledge of the anatomy that these palatine tonsils, they lie in the bed that is formed by superior constrictor muscle. So remember, when we discussed the pharyngeal wall, we saw the superior constrictor muscle and we also saw the palatine tonsil over there. So the bed is formed by superior constrictor. Remember, the anterior tonsillar pillar is formed by palatoglossus and the posterior tonsillar pillar is formed by palatopharyngeus. Okay, but the bed is formed by superior constrictor muscle. Okay, now you see there is a space. There is a space between the superior constrictor muscle and the fibrous capsule of tonsil. This space is known as peritonsillar space. Right? So you can see over here that we have this space, and this space is now known as peritonsillar space. Now, this is not a true space. Why? Because normally there is no space over here. It's just a place, and this place is filled by fibrous tissue. But if there is an infection, now this space will enlarge, it will become a space, it will be filled with pus, and now this is known as peritonsillar abscess or quinsy. Okay, so remember that the peritonsillar space, this space is not a true space, this is a potential space. Okay, and when there is an infection in this space, it is known as peritonsillar abscess or quinsy. Right? Let us talk about peritonsillar abscess or quinsy. Now, how will a patient of peritonsillar abscess or quinsy present to us? What will be the problem with this patient? You see, there is an abscess. There is an abscess in the mouth, in the oropharynx. So what will the patient have? Number one, the patient will have pain in throat, of course. There will be a lot of pain. There is an abscess. What else? Patient will also have fever. Any other problem? Patient will have difficulty in swallowing. Patient will have dysphagia. Okay, if he tries to swallow, there will be a lot of pain. Patient will have odynophagia. So the patient presents to us with these complaints. What do? We ask the patient to open the mouth. Now when the patient opens the mouth, what do you see? You see that on one side, what do you see? The tonsil is red and large congested tonsil. So you see there is a unilateral tonsillar hypertrophy. The tonsil on one side is red and large congested. What else do you see? You see that this enlarged tonsil is pushing the soft palate and the uvula to the other side. So the soft palate, you can see clearly, has been pushed to the other side. And if you look at the uvula, what do you notice? The uvula is pointing towards normal side. Okay, the uvula, you can see the tip of the uvula, it is pointing towards normal side, away from the quinsy. Right? This is how you will identify, you will diagnose that this is a case of quinsy. Right? Okay. Other than this, Sometimes patient may also complain of a voice change, and that is known as hot potato voice. Hot potato voice you can also called as muffled voice. Now what is this hot potato voice or muffled voice? Now you see there is an infection in the oropharynx. Right? There's an infection in the oropharynx, in the tonsillar peritonsillar space. Now because of that, the oropharynx and the muscles surrounding it, the pharyngeal muscles, they will undergo spasm. So when we speak from the larynx, what we speak from the larynx is the vowels. A, E, I, O, U. So these are the vowels and they come from the larynx. Now these vowels are then converted into consonants in our pharynx, in our oral cavity, by the tongue, by the lips. Suppose I have to say ma, so it comes from the lips. Whereas I have to say ka, the ka comes from the palate. Right? But if there is an infection, so all the consonants which arise from the palate, from the pharynx, they will not be there. So patient will have a voice, a typical voice that's known as muffled voice, also known as hot potato voice. Suppose you have put a hot potato in the mouth and now you try to speak, so it is causing some burn, some irritation, and your pharyngeal muscle is in spasm, so you will speak in a very hasty way and the voice will be unclear. Suppose somebody has muffled it, so that's known as hot potato voice. Okay, now remember, students normally try to correlate the hot potato voice with quinsy. It's okay, but hot potato voice is also seen in other conditions of the pharynx. If there is an acute infection, such as acute retropharyngeal abscess or acute parapharyngeal abscess, okay, so if there is an acute infection, such as an acute parapharyngeal abscess, we'll be discussing this soon. And suppose if there is an acute epiglottitis, so again in these conditions also patient will have hot potato voice or muffled voice. So hot potato voice or muffled voice is seen in quinsy, but it is not only seen in quinsy, it is also seen in other conditions. Right? Okay. Now what will we do for treatment? Look at this photograph. So this is a clinical photograph. What you see over here, you can see that this tonsil is enlarged. Right? You can see the uvula over here, and the uvula is pointing towards the other side. The soft palate over here is pushed to the other side. Okay, what treatment will you do for this patient? So the number one treatment that you have to do is you have to drain the abscess. You have to drain the abscess. Okay, so that means you have to do intraoral incision and drainage. Now where do we do this incision? We give this incision over here. Okay, we give it over here near the superior pole. All right, number two, what else will we do? See, this is an infection, we have to give IV antibiotics. So this IV antibiotics we have to give for 10 to 14 days so as we have to achieve complete resolution of the infection. Okay, and in these scenarios we also advise the patient to undergo tonsillectomy. Okay, because the infection can recur, we also advise tonsillectomy. Now this tonsillectomy is done 6 weeks after the episode of quinsy. All right, it is not done immediately. It is done 6 weeks after the episode of quinsy. So that is why it is known as interval tonsillectomy. Okay, now remember, some books have written over here 4 to 6 weeks after quinsy. Now that seems a very benign change in the words in this, that 4 to 6 weeks or 6 weeks. But a question has been asked that interval tonsillectomy is done, less than 2 weeks, 2 to 4 weeks, 4 to 6 weeks, and after 6 weeks. So you see Our answer is clear. It is after 6 weeks. Some books I know have mentioned 4 to 6 weeks, but that is a wrong option. We do not operate till 6 weeks of quinsy. Why? Because you see, this is a state of inflammation. It is a state of infection. And now what happens in inflammation? In inflammation, the blood supply increases. So when the blood supply increases, suppose I operate at the time of quinsy, what will happen? There will be a lot of bleeding. All right. And we will call it as hot tonsillectomy. Because there's a lot of bleeding at the time of quinsy, you call it as hot tonsillectomy, and hot tonsillectomy is not advisable. It is risky for the patient, right? So that is why you will wait for at least 6 weeks so as the inflammation should subside, okay? And then when you do tonsillectomy, you do not have so much bleeding. So tonsillectomy is interval tonsillectomy. It is done 6 weeks after quinsy, okay? Right. Let's come back over here to this question. Now, a 6-year-old boy presented with fever with pain. So there is fever and there is pain in the throat, all right? And difficulty in deglutition, dysphagia. On examination, following findings are seen. So 3 main presenting symptoms of quinsy has been mentioned to you. And what do you see? You see one side tonsil is enlarged. It is red, it is congested. What else do you see? You see that the uvula is pointing towards the opposite side, towards the normal side. Okay, so what is the most likely diagnosis? The most likely diagnosis over here is peritonsillar abscess. Okay, the remaining options, parapharyngeal abscess, Ludwig's angina, retropharyngeal abscess, these we will discuss in some time shortly. All right, but over here the answer is clear cut. You can see it is peritonsillar abscess. This question was asked very recently in the NEET PG January 2020 exam. Okay, let's go back over here to the blood supply of tonsils. So the tonsils, they are supplied by 5 arteries. What are the 5 arteries? You can remember them by a simple mnemonic, TADAD. So what is this? Number 1, we have the tonsillar artery. This is the main blood supply of tonsillar artery, and this is a branch of facial artery. Right? Okay, there is another branch of the facial artery that supplies the tonsil, and that is known as ascending palatine artery. So this is again a branch of facial artery. Okay, number 3, we have the descending palatine artery. So easy to remember, ascending palatine, descending palatine, and then we have ascending pharyngeal artery. Okay, now you see over here the descending palatine artery is also a branch of maxillary artery. Okay, the ascending pharyngeal artery, however, is the branch of ECA. Remember, this is the only medial branch of ECA. Only medial branch of ECA. Remember, this question has been asked many times in the exam, which is the first branch of ECA. Now, the Gray's Anatomy, the BD Choracea, they do not tell you which is the first branch. They just enumerate 1, 2, 3, 4, 5, 6, and they don't say which is the first branch. And when they say, when they enumerate 1, 2, 3, 4, 5, 6, at number 1, they place superior thyroid artery. So that is the answer most students mark. But remember that this branch, ascending pharyngeal artery, this is also the first branch of ECA. It arises on the medial aspect, so it is not visible to us when we do the dissection, and it separates quite high up from the ECA, but this is also the first branch of ECA as mentioned in the Cunningham's dissector of anatomy. Right? Now, what else supplies the tonsils? We have the lingual artery. So look at the lingual artery. It gives a branch known as dorsal lingual artery that goes and supplies the tongue as well as the tonsils. So you can see over here there are 5 arteries which are supplying the tonsils. Number 1 we have Tadad. So number 1 we have tonsillar artery. Number 2 we have ascending palatine. Number 3 we have descending palatine. Number 4 we have ascending pharyngeal, and number 5 we have dorsal lingual artery. Okay, remember the ascending palatine and descending palatine. In the nose there was one artery which was very, very important, and that was sphenopalatine artery. So remember, the sphenopalatine artery is important in nose. It does not supply the tonsils. That's a question. Another artery which was there along with sphenopalatine we studied in the nose was greater palatine artery. So again, greater palatine artery is supplying the nose. Okay. In the tonsils we have ascending and descending palatine arteries. If you remember that, you will be able to solve your question. Now you see, all these 5 arteries, they are branches or sub-branches of ECA. The ICA does not supply the tonsil. All these branches are branches of external carotid artery system. Right? So that was the blood supply of the tonsil. What is the venous drainage? So you can see over here, this is the peritonsillar space. Okay, so you can see the peritonsillar space, that is the space between the fibrous capsule and the superior constrictor muscle over here. And in this peritonsillar space, we have a vein over here that is known as paratonsillar vein. So this vein, the paratonsillar vein, it drains the venous drainage from the palate, soft palate you can see, as well as from the tonsils, and it goes and drains into the facial vein. So the paratonsillar vein is the venous drainage of the tonsils. Right? Okay. Another important thing you have to note before I go ahead, and it is very, very important. What you can see over here in this diagram, you can see over here that we have the tonsils. So this over here is the palatine tonsils. Around the palatine tonsils, you can see we have a fibrous capsule. After the fibrous capsule, I explained to you that there is peritonsillar space. That is also all right. Now, after the peritonsillar space, you can see the superior constrictor muscle. That is also all right. We have seen that. Now, please notice one thing, that superior constrictor muscle, around both the side there are 2 fascia. Remember the wall of the pharynx, 4 layers. First layer is mucosa. The second layer is the fascia. Which fascia? We have the pharyngobasilar fascia. So you can see this fascia, the pharyngobasilar fascia. Then there is superior constrictor muscle, the muscular layer. And then there is another fascia over here. You see there is one more fascia. Which is this fascia? This is your buccopharyngeal fascia. So you can clearly see the buccopharyngeal fascia. Right? Now, if you go outside this buccopharyngeal fascia, you can see over here there is a nerve. There is a cranial nerve. This is the 9th cranial nerve, the glossopharyngeal nerve. Okay, so you can clearly see the nerve, the glossopharyngeal nerve over here, the 9th cranial nerve. Now, what is the significance of this glossopharyngeal nerve? Suppose there is an inflammation in the tonsils. There is acute tonsillitis. Okay, what else can be there? Suppose you do tonsillectomy. You do tonsillectomy. Now, in any of these conditions, what can happen? The inflammation or the injury because of tonsillectomy, it can affect the 9th cranial nerve, the glossopharyngeal nerve. So there is an inflammation it can go and affect the ninth cranial nerve. Suppose you do tonsillectomy, you may injure the ninth cranial nerve. Okay, now what will happen? So also in case of quinsy, if there is an infection, quinsy again, it can affect the ninth cranial nerve. What will happen? This will cause rough-foot pain into the ear. Now remember, in the ear we have a nerve. Which nerve? We have the Jacobson's nerve. Now the Jacobson's nerve, this is a branch of glossopharyngeal nerve. And remember, the Jacobson's nerve is the sensory supply for whole of middle ear. All the walls of middle ear, they are supplied by Jacobson's nerve, which is a branch of glossopharyngeal nerve. And therefore, if the glossopharyngeal nerve is irritated, it may cause rough-foot pain in the ear. Okay, so remember that the glossopharyngeal nerve is responsible for rough-foot pain into the ear because of acute tonsillitis or during quinsy or after tonsillectomy. Right? Okay. Now, let us come back to the tonsils. What is the function of these tonsils? As we discussed, they are a part of ring known as Waldear's ring. Right? So they fight against infection. Whenever the infection, the bacteria or the viruses, the pathogens, they try to enter into the body, these tonsils, they will capture them and they will try to stop them. As a result, they will become inflamed. So this condition is known as acute tonsillitis. It's a normal body response to the infection, acute tonsillitis. Right? The most common causative organism causing acute tonsillitis is hemolytic streptococci. Right? Now, this acute tonsillitis can be of different types, or I can say different grades. The most common acute tonsillitis is acute catarrhal tonsillitis. Now, what happens in acute catarrhal tonsillitis? This acute catarrhal tonsillitis is in response to viral infection. Okay, respiratory infection. Now what happens? In response to the virus infection, these tonsils, they will become red and congested. They will not increase in size. They will just become red and congested. Okay, so we know that there is a viral infection in the pharynx, in the oropharynx, the tonsils. The second is acute follicular tonsillitis. Now, acute follicular tonsillitis is generally seen in bacterial infection, and it denotes that the bacteria has now gone into the tonsillar crypts. Okay, the bacteria has entered into the crypts, and when it goes inside the crypts, there is formation of pus. Okay, this pus, as you can see over here, it comes on the crypt opening. Right? So on the crypt opening of the tonsils, you can see a lot of pus points, and that denotes that there is bacteria inside the crypts. So that is known as acute follicular tonsillitis. Right? Now, the next is acute parenchymal tonsillitis. Now, what happens in acute parenchymal tonsillitis? Now, the infection goes into the parenchyma, into the lymphoid tissue of the tonsils. What happens? As a result, the tonsils increase in size. There is a tonsillar hypertrophy. They increase in size. Right? Okay. Now, this hypertrophy of the tonsils, we can divide into 4 grades. So, what are the 4 grades? The grade 1, you will see small tonsils. They are red, congested, they are slightly enlarged, but they are still inside the tonsillar fossa. Inside the tonsillar fossa means they have not crossed the margin of anterior tonsillar pillar and posterior tonsillar pillar. Alright, so that is grade 1. Now, what is grade 2? Now, grade 2 is that they have come outside the tonsillar fossa. As you can look in this photograph, they have come outside the tonsillar fossa. But if you measure the distance of the uvula to the tonsillar fossa, they have not even covered 50% of this distance. Okay, so not even 50% of that distance is covered by these tonsils. That's a grade 2 tonsils. Now grade 3 tonsils, the grade 3 tonsils, they have crossed that 50% distance. So they are more than 50% of the distance between the uvula and the tonsillar pillar. All right, when you patient says ah, suppose the patient tries to say ah, these tonsils may come and meet in the midline. So that is a grade 3 tonsillar hypertrophy. They meet in the midline when the patient says ah. All right, and then we have grade 4 tonsils. Grade 4 tonsils means they are completely meeting in the midline. They are always meeting in the midline. All right, even when the patient is not saying anything, they are meeting in the midline. So they are completely blocking the oropharyngeal pathway. All right, so these grade 4 tonsils you can see over here, this grade 4 hypertrophy is known as kissing tonsils. So as you can see over here that these tonsils, they are completely blocking this oropharyngeal pathway. They are meeting in the midline in all the times. So that is why they are known as kissing tonsils. Okay, so that was acute parenchymal tonsillitis, and then we have acute membranous tonsillitis. Now, what do we mean by acute membranous tonsillitis? Now, remember this photograph we saw in the acute follicular tonsillitis. There is formation of pus at the opening of the various crypts. Now, what happens in acute membranous? These pus points, they all coalesce. Okay, they all fuse together and then they form a membrane over the tonsils. So, there are a lot of conditions which can mimic acute membranous tonsillitis. So number one, we discussed that this membranous tonsillitis or a membrane over the tonsils can be because of a bacterial infection. So that is known as pyogenic infection. So that's known as pyogenic tonsillitis. So acute membranous tonsillitis is because of bacteria, okay, the hemolytic bacteria, and this is a pyogenic tonsillitis. But there can be other differential diagnosis for a membrane over the tonsils. So what can be the other differential diagnosis? Let's see over here we have fascial diphtheria. Okay, so there is diphtheria in the oropharynx caused by bacterium known as Corynebacterium diphtheriae. Now, how do we differentiate? How will this patient of a fascial diphtheria present to us? Now, this presentation is very, very typical. Okay, what's the typical? You see, this patient is generally of the age group 2 to 3 years. So, remember, diphtheria happens in children. And to prevent this diphtheria infection, what we do is we give immunization. So, right after the birth, 6 weeks, 10 weeks and 14 weeks, 6, 10, 14, we give the DPT vaccination, diphtheria, pertussis, tetanus. So, we give this DPT vaccination to prevent diphtheria, number one. Okay. Now, this patient will be a non-immunized child. You see, immunization practically rules out diphtheria. So, that means this child have not undergone any sort of immunization. So, 2 through 3 years, children. Number 2, non-immunized child. Very, very important history. Okay. Now, what can the patient have? Patient can have fever. Now, remember, the fever may be mild to moderate. Why? Because diphtheria progresses very fast. So, fever may be mild to moderate. It may be somewhere around 38 degrees Celsius. So, not very high. Okay. But diphtheria progresses very, very fast. So, patient may have a toxic appearance. That is very important. Patient has a toxic appearance. Now, you examine this patient. What do you see? So, what do you see? You see bilateral cervical lymphadenopathy. Now this bilateral cervical lymphnopathy is very, very typical in diphtheria, and this is known as bull neck. Okay, so that's known as bull neck. Now when you examine in the oral cavity, you may see that bilateral tonsils are enlarged. And there is a membrane over the tonsils. So look over here, there is a membrane over the tonsils, and this membrane is a dirty gray color membrane. Okay, so this is a dirty gray color membrane. If you try to peel off this membrane, it will leave blood spots. Okay, so it peels with bleeding. So that means it is not a true membrane, it is a pseudo membrane. So remember, the diphtheria, it forms a pseudo membrane on the tonsil, it peels with bleeding. Right? Okay, now how will you confirm your diagnosis of diphtheria? You see, patient is already toxic. You have to start the diphtheria antitoxin as soon as possible to save the child. Otherwise, the child may have heart problems such as myocarditis, congestive heart failure. Okay, so you have to immediately start the diphtheria antitoxin, which is started even on suspicion. But what you can do immediately is you can take a throat swab and send that swab for staining. Okay, so what will you do? You will do Albert stain. Right? You do Albert stain, and you have read this in microbiology. You put Albert A, then you put Albert B, and then what do you see? You see the diphtheria, the Corynebacterium diphtheriae, it has these metachromatic granules. So because of these metachromatic granules, there is formation of Chinese letter appearance. Okay, so that is seen in Corynebacterium diphtheriae on Albert staining. Right? The treatment, we have to immediately give the diphtheria antitoxin. The diphtheria antitoxin is given as per the time duration of the diphtheria infection, whether it is less than 48 hours of onset of symptoms or after 48 hours. If it is less than 48 hours, we may need to give 20,000 to 40,000 units. If it is more than 48 hours, we may have to give 80,000 to 1,20,000 units of diphtheria antitoxin just to neutralize the toxin in the body and save the patient. Okay, and thereafter we treat the infection by giving the benzyl penicillin injections as per the weight. All right, so that is given to treat the bacterial infection. Right? Okay, look over here in this photograph. This is the typical photograph for the bull neck. You can see that is because of bilateral cervical lymphnopathy, very, very typically seen in case of diphtheria patients. All right. Now, what can be the other DD for membrane over the tonsillitis? We have infectious mononucleosis. Okay, infectious mononucleosis is caused by Epstein-Barr virus. Now, the presentation of infectious mononucleosis is almost similar to diphtheria. Okay, how? Patient will have fever, patient will have bilateral cervical lymphadenopathy, and patient will also have bilateral tonsillar hypertrophy, and there is a membrane over the tonsils. Okay, now how is this different? So we have seen the similarity. How is this different? When do I say it is infectious mononucleosis? So just by the first look, you see the age group, very, very important. Diphtheria, the age group was 2 to 3 years. Infectious mononucleosis, it occurs in young peoples. So that means the age group is 20 to 30 years. Remember, it spreads by kissing. The virus spreads by kissing. So the age group is seen in young people, that is around 20 to 30 years age group. Very important. The age group will isolate it into a different category. Right? So infectious mononucleosis, what else can you see? Look in the photograph. You see over here that this is a viral infection. So patient may have palatal petechiae. So you see over here, You can identify the palatal petechiae, very, very typical for a viral infection, such as in case of infectious mononucleosis. Other than that, we can also have membrane over the tonsils. Now, how do we confirm whether it is infectious mononucleosis? You can do a blood test, and what is that? We have the Paul Bunnell test or the monospot test. Okay, so that is done specifically for infectious mononucleosis. Otherwise also, if you do a normal CBC, complete blood counts, you will see that it is a viral infection, the leukocytosis infection, the leukocytosis is there. In fact, the lymphocyte count is increased. Okay, so patient has lymphocytosis, and you see the 10% of cells in peripheral smears. The 10% of these will be atypical cells. So if you do a peripheral smear, you will find that 10% cells will be atypical cells. So that points towards infectious mononucleosis. Of course, we can confirm by the Paul Bunnell test, also known as the monospot test or the heterophile antibody test. Right? Okay. Next we come to candidiasis. So candidiasis, it is also known as oral thrush, caused by the fungus Candida albicans, and it is seen in immunocompromised patient. So you see, the patient profile, the history is very, very important to differentiate between different types of membrane. Now the patient is an immunocompromised patient. Okay, so patient is an immunocompromised patient, such as a diabetic patient with uncontrolled sugar, or patient may be HIV/AIDS patient, leukemia, lymphoma patients. But the most important which we generally forget, okay, is patient. He may not be a immunocompromised patient, but he may be a asthma or a COPD patient on inhalational steroids. Okay, so local immunocompromised state, he is not systemically immunocompromised, he is a asthma COPD patient, and most of the times we will see such patients in our OPD who are taking inhalational steroids, and they come to us with a membrane over the tonsils, and not just the tonsils, the membrane may be on uvula, on the soft palate, buccal mucosa. So that's known as oral thrush. It's a Candida albicans infection. Okay. Another condition, we have Vincent's angina. Now the Vincent's angina is also known as trench mouth. Okay, and there is a acute necrotizing gingivitis. All right, so you can see over here, there is an acute necrosis of the gingivae, and this Vincent's angina, it is caused by which bacteria? It is caused by a spirochete known as Borrelia vincenti, and it causes Vincent's angina in collaboration with Fusobacterium nucleatum. Okay, so that's important. It collaborates with Fusobacterium nucleatum and it causes Vincent's angina, also known as trench mouth. Okay, again there is formation of a membrane which bleeds on peeling. So there it can form a membrane on the tonsils, and this bleeds on peeling, right? So that is your Vincent's angina. Remember, Vincent's angina is associated with a membrane over the tonsils. We have a term known as Ludwig's angina. So we will be studying Ludwig's angina in some time in the topic of the deep neck spaces, but just remember, Ludwig's angina is not at all related to the tonsils. This is an infection of the submandibular space. So this question comes in the exam. Which of the following condition is not related to membrane over tonsils? So remember, Ludwig's angina is not related to membrane over tonsils. what is related to membrane over tonsils? We have Vincent's angina. Okay, don't confuse the two. They are two very, very different conditions, right? And then we have agranulocytosis. Now, agranulocytosis is generally seen in leukemia, lymphoma patients on chemotherapy, and there is formation of ulcerative lesions, not just on the tonsils, but other parts of the oral cavity, such as you can see on the palate, on the buccal mucosa, on the tongue. All right. So all of these may present like a membrane over the different places, such as a membrane over the tonsils, and we may have to differentiate. Now, easy way to differentiate is just take a history, or on the blood count, you will see that the leukocyte count is less than 2000. Okay, so that will confirm a diagnosis of agranulocytosis. Lastly, we have aphthous ulcers. Aphthous ulcers, they are also known as canker sore, and they form in a lot of different conditions, such as due to stress, such as due to multivitamin deficiency, or in diarrhea, constipation. We have these aphthous ulcers, right? Now, sometimes these ulcers may be very big and they appear like a membrane, especially on the tonsils, right? Now, how do we differentiate these aphthous ulcers? So remember, these aphthous ulcers by the history are extremely painful. So much painful that the patient is not even able to swallow liquid. Forget about the solid, he is not able to swallow even the liquid. So the odynophagia is very, very severe. Okay, the odynophagia in the patient is very severe, right? Now, what else? When you look at this ulcer, you will see that all around the ulcer there is a red margin. There is a red margin all around the ulcer, and there may be some inflammation around the red margin, but there is a typical red circle, a red margin around the ulcer, and when you see that red margin, you will be sure that it is a case of aphthous ulcer, right? Okay, so these are the different conditions that can mimic a membrane over the tonsils. All right, now let's look at this question. It was asked in the NEET PG January 2019. An unimmunized, you see, the very first word gives that a very, very strong hint. An unimmunized, second 2-year-old girl. 2 hints. Unimmunized 2-year-old girl presents with high-grade fever and sore throat. On examination, she is toxic in appearance. So remember, I told you the patient is toxic, very important, and having bilateral cervical lymphnopathy. What do we call this condition? I know you must have guessed by now. By the history itself, we know that this looks like a bull neck over here. Throat examination shows below finding. You can see a membrane over the tonsillar area. Okay, what is the most likely diagnosis? We know that this is a case of diphtheria. Clear cut. Lot of hints have been given to you. Number one is most important hint is unimmunized. Okay, if this would have been changed to immunized, we can never make the diagnosis of diphtheria because immunization practically rules out diphtheria for us. Right? Okay, so answer to this question was a clear cut diphtheria as the answer. Even if the diagram, this photograph was not given, the history was typically pointing towards diphtheria. Okay, now let us come to chronic tonsillitis. So we have seen the different types of acute tonsillitis. Let's come to chronic tonsillitis. So what do we mean by chronic tonsillitis? It means a chronic inflammation of the tonsils. Now we know that these tonsils, they are meant to fight against the bacteria. So they swallow the bacteria, they fight, they destroy it, it's finished, they go back to their original size. Now sometimes what happens, the bacteria, it starts living in the crypts. So remember, we saw the crypts, they were formed by the capsule. And these crypts, they are blind spaces. So the bacteria starts living in the crypt. It colonizes the crypts. So what happens now? Because of that, there's a chronic inflammation in the tonsils. The tonsils may increase in size. There may be constant formation of pus points on the tonsillar surface. Okay, so we may have a chronic follicular tonsillitis. Okay, so there is chronically formation of pus on the crypts, or we may have a chronic parenchymatous tonsillitis. That means tonsils are enlarged. Okay, we may have a chronic atrophic, or I could say fibrotic tonsillitis. Okay, now in this, the tonsils have undergone fibrosis. Okay, it has become hard, but there is infection inside it. Now, how do we know whether this a fibrotic tonsil, it's a small tonsil, it has infection in it? Okay, for follicular and parenchymatous, you can see the tonsil size is big, or there is pus point on the tonsil crypts. So you know that this tonsil is infected. What about the fibrotic tonsil? Now what you do is you press over the tonsillar fossa, the anterior tonsillar pillar. Okay, so you press over the anterior tonsillar pillar and you will see that the cheesy pus comes out from the crypts, and that is known as Irwin-Moore sign. So Irwin-Moore sign is you press on the anterior tonsillar pillar and the pus comes out from the crypt of the tonsil. That shows it is a chronic tonsillitis. So this is very important. If the tonsils is a fibrotic tonsil, it will confirm that there is infection inside the tonsil. Okay, other than this Irwin-Moore sign, we can also see that the anterior tonsillar pillar, this will be more congested than the surrounding mucosa. Okay, so this anterior tonsillar pillar will be more congested, and you will also find cervical lymphadenopathy. So all this points towards chronic tonsillitis. Now, what treatment will you do for chronic tonsillitis? You see, we usually give antibiotics, and that solves the problem. We have very good antibiotics nowadays, but these antibiotics, they treat the infection. They are not able to, however, go inside the crypts. So because they are not able to go inside the crypts, the bacteria, it survives the course of antibiotic. So what happens? After the antibiotic course is over, slowly and slowly it will again grow, and it will again cause sore throat, pharyngitis and tonsillitis. Right? So chronic tonsillitis, it becomes problematic when it does not respond to the antibiotic, when there is recurrent episodes of sore throat, pharyngitis. Then the patient is concerned and he comes to you. So what will you do in this circumstance? See, the antibiotic is not working. The option in front of you is to remove the tonsils. Okay, you have to do tonsillectomy. So you have applied the medical treatment, the patient is not responding to the medical treatment, there is a recurrence of sore throat, pharyngitis, you have to do tonsillectomy, you have to remove the tonsils. Okay, so let us discuss tonsillectomy. First thing, we will discuss what are the indications of tonsillectomy. What are the indications of tonsillectomy? When do we decide that we have to remove the tonsils? So as I said, we will do tonsillectomy when there is recurrent sore throat. When there is recurrent attacks of sore throat. Okay, when will I call that this is a recurrent sore throat? What do I mean by recurrent? Now, recurrent means more than equal to 7 episodes in 1 year, or more than equal to 5 episodes per year for 2 years, or I can say more than equal to 3 episodes per year for last 3 years. Okay, last 3 consecutive years. So when I say last 3 years, they have to be last 3 consecutive years. If there is a gap in between, then we will not consider it as 3 as a criteria for tonsillectomy. Okay, so last 3 consecutive years, or the child misses school or work for more than 2 weeks, more than 14 days in 1 year. Okay, that is the criteria for recurrent sore throat. Okay, when we decide to go for tonsillectomy, this falls under a criteria that is known as Paradise criteria. Okay, so this criteria is known as Paradise criteria. Remember, Paradise criteria is a very big criteria. This is only a part of Paradise criteria where it defines what is recurrent sore throat. Okay, so in the history, it defines the recurrent sore throat, and this is taken as an indication for tonsillectomy. Right? Okay, so whenever you are preparing for your PG entrance exam, a lot of students, they ask me, so what is the best way to prepare? I always say, you see, the most important thing in the PG preparation is revision. The most important thing. It is not important how much you have studied. Okay, it is not important, how much depth you have gone. If you have not been able to revise what you have studied, it is a waste. Because in the exam, you will not be able to recall. And the worst situation is, you are able to recall, but you are confused between the options. That is even a worse situation, because you don't know a topic, you will miss that question, you will go and apply your brain to the next question, but you know a topic, you have studied it, you know the question, you are confused between the options, you will waste more time. Okay, so I always say that you have to revise. Now, how many times should I revise my course? How many times? So, what amount of revision we should do to clear our exam? So it's very easy. We want to achieve a goal. We want to get a seat in a desired college. Our seat which we desire in our dream branch, in a dream college. So a revision, our course preparation should make us achieve that goal. So for that, how many revisions do we need? Okay, so if you want to clear in the first attempt, you need more than equal to 7 revisions in 1 year. If I say ideally, I would have said the number 10. 10 is the ideal number, but at least it should be 7 revisions. Why? Because I have seen it. By the 4th or the 5th revision, you remember the things. By the 1st, 2nd revision, you are only understanding and you try to forget. By the 5th revision, you start remembering the things very nicely. They are all in your head. Okay, but sometimes you may get confused between the choices. Only by the 7th revision, there is no confusion left. Okay, so you need 7th revision at least so as to forego all the confusions. Right? So, if you are not able to do 7 revisions, remember, students who do 5 revisions, 5 or more, they say, I can do only 5 revisions. So you see, students, if you do 5 revisions, so you'll need 5 revisions per year for 2 years. In the 2nd year, you are generally able to clear the exam. You see, so it automatically reaches up till 10 revisions. Okay, and if you think you are very, very slow, you will not do more than 3 revisions. So remember, if you do 3 or more revisions for 3 years, and then in the 3rd year, you are able to clear the exam. So it again goes to 9 to 10 revisions. Right? So that is how it works. And I know medicine, this whole MBBS, it's a vast subject, a vast course. We have 19 different subjects. It's not possible to revise all the 19 subjects in the first year. All right. So how many subjects should I undergo for so many revisions? So the minimum number of subjects that you need to revise like this is 14. So you can see these are the same figures that we just discussed. Okay, so 7 episodes per year, first year, 5 episodes per year for 2 years, 3 episodes per year for last 3 years, or 14 days in 1 year. So this criteria is not just the criteria for tonsillectomy. This paradise criteria is also for you to reach your paradise, to get your dream branch in your dream college. Okay, so remember this criteria. It is the criteria for you how you must prepare for your exams. Right? Okay, as I will again say कि you must read what you can revise. Right? So everyone says that you must read what you can revise. I'll go one step ahead and I'll say what you cannot revise, you must not even attempt to read it once. It's clear for PG exam, if you cannot revise something, there is no need of studying that thing. Okay, so read what you can revise. What you cannot revise, no need to read it. Okay, revision is more important than doing the course completely. Okay, so that was the first indication for tonsillectomy, that is your recurrent sore throat. What else we can do? What are the other indications? We have quinsy. Quinsy we have already talked earlier. In quinsy, what we do is interval tonsillectomy. Okay, so interval tonsillectomy means 6 weeks after quinsy. 6 weeks after quinsy, we do tonsillectomy. It is known as interval tonsillectomy. If we do immediately at the time of quinsy, there will be a lot of bleeding, and that is known as hot tonsillectomy. This we don't prefer to do. Right? Now, quinsy, remember, second episode in an adult. Second episode in an adult and single episode in a child. This is an absolute indication for tonsillectomy. So remember, right now we are talking about only the absolute indications. So recurrent sore throat, what all I have told you was the absolute indication. Now this is also the absolute indication. So second episode in an adult and single episode in a child, this is an absolute indication for tonsillectomy. Okay, now the next indication is if the child is having obstruction. The tonsils are causing obstruction. Okay, the child is not able to swallow, or there is difficulty in breathing. They are blocking the airway, or the child is having OSA, obstructive sleep apnea. So any of this reason, you have to remove the tonsils. They're causing obstruction. Number 4, if the child is having febrile seizures. So every time the child has fever, the child has seizures. So the seizures are because of fever. The fever is because of the sore throat, the tonsillitis. Okay, so you have to remove the tonsils, right? And number 5, if there is a unilateral enlargement and you suspect that there is a malignancy, so you go and you do the biopsy for the malignancy. Okay, so for taking this biopsy, you have to remove the complete tonsil. That means you have to do tonsillectomy. So these are the indications for tonsillectomy, right? Okay, now you have prepared the patient for tonsillectomy. Now on the day of the operation, how will you position the patient? What is the patient position? The patient is positioned in the rose position. Okay, now what is this rose position? How do we remember the rose position? Okay, now you see in this rose position, what we have done is we have placed a shoulder bag. So you can see over here, there is a shoulder bag placed below the shoulder, and because of this, the cervical joints as well as the thoracocervical joints, both of them, they are in extension, in hyperextension. Okay, so the cervical joint as well as the thoracocervical joints, both are in extension. Okay, so that is known as rose position. The advantage of rose position is if there is a bleeding during tonsillectomy, it prevents the blood from going into the trachea and bronchi. That means the respiratory pathway. So it prevents the aspiration of blood. Okay, so that is why we use rose position. The thoracocervical and the thoracocervical joints both are in extension. Right? Okay, how do we remember the rose position? How can we easily remember the rose position? Now, to remember the rose position, remember a boyfriend. A boy goes to propose a girl. Okay, so what will he take with him? He takes a rose. Now, how will he give the rose to the girl? There is a classical position. So, I think you all know how to hand over a rose to a girl. The boy kneels, he goes to one knee. Okay, and he hands the rose like this, looking in the eyes of the girl. Okay, when he is giving the rose like this to the girl, look at the neck. What happens to the neck? The neck is in hyperextension. The cervical joint as well as the thoracocervical joint both are in hyperextension. Okay, so that is known as rose position. So remember the rose position, the boy is giving the rose to the girl, and where is he looking? Very important. Where is he looking? He's looking in the eyes of the girl. Then only both the joint, even the thoracocervical joint, will be in hyperextension. So that is known as rose position. Suppose he is not looking in the eyes of the girl and he is looking somewhere down. Now what happens? Now only the cervical joint is in extension, whereas the thoracocervical joint, it goes in flexion. Okay, that will not be a rose position. That will be known as barking dog position, or you can say boy's position or morning sniff position. Okay, so boy's position or morning sniff position or barking dog position, you see over here, the cervical joint is in extension, but the thoracocervical joint, this is in flexion. Okay, the thoracocervical joint is in flexion. So this is known as boy's or morning sniff or barking dog position. Okay, this position is used for, you can see over here, endotracheal intubation. So what do we do during endotracheal intubation? We first do laryngoscopy. So this position is used for laryngoscopy, it is used for bronchoscopy, it is used for esophagoscopy. We see over here there is no shoulder bag. There is no shoulder bag placed. So the cervical joint is in extension, but the thoracocervical joint is in flexion. Alright, so that is known as boy's position or barking dog or morning sniff position. Right? For what we do? For tonsillectomy, what position do we use? We use rose position. Okay. Now, where else can we use the rose position? So, number one, I told you we use it in case of tonsillectomy. Other than this, we can also use it in case of adenoidectomy, and we can also use this position in case of tracheostomy. Okay, so in all these we use the rose position. Right. Now, what are the complications of tonsillectomy? What are the complications of tonsillectomy? You see, as we discussed during the position, the boy has gone to propose the girl, he is giving the rose. So what can happen? What can happen? The girl may accept the rose, so proposal is accepted. Or the girl may reject the proposal. So what can she do? She can slap the boy. So if she slaps the boy, there will be bleeding, there will be hemorrhage. So remember, the most common complication of tonsillectomy is hemorrhage. Okay, the most common complication for tonsillectomy is bleeding, hemorrhage. Now this hemorrhage can be of three types. It can be of how many types? Three types. The number one is primary hemorrhage. So what do I mean by primary? What do I mean by primary? You see, the boy gives the rose to the girl, the girl immediately slaps him. Okay, that's primary hemorrhage. Intraoperative, at the time of surgery, intraoperative. Okay, now when the girl slaps the boy, what kind of slap will that be? That will of course be a soft slap. Okay, so that will be a soft slap. Therefore, the primary hemorrhage is because of paratonsillar vein. It's a venous hemorrhage. Not very massive. It's a venous hemorrhage. Okay, from the paratonsillar vein. This is the most common source for primary hemorrhage. And how do you control this? How do you control this? The best way to control this is you say sorry to the girl. Okay, so you fold your hands and you say sorry and you go away. At the max, what you can do is you can hand a friendship band to the girl. Okay, tell her we will be friends. I'm sorry, I'll not do anything else. So you hand a friendship band, right? So similarly, paratonsillar vein, you see bleeding, what you do is you just hold it and you put a suture over there. So suture ligation. Okay, so you ligate this vein with the help of a suture. It will stop the bleeding. So paratonsillar vein, the treatment is suture ligation. Okay, so that was your primary hemorrhage. Now let's say your suture does not work. Okay, your friendship band, the girl throws away the band, she goes home and she has a boyfriend. She already has a boyfriend. She immediately calls her boyfriend and tells him that you have proposed her. So what will happen? Now there will be a reaction. Okay, the boyfriend will react. So now we have reactionary hemorrhage. Okay, so this reactionary hemorrhage will take place within next 24 hours. Okay, now the boyfriend is looking for you. Okay, he'll search for you and he'll try to beat you. So that is your reactionary hemorrhage. Reactionary hemorrhage works. The reactionary hemorrhage occurs because your suture has not worked. It has slipped away. Okay, so it is because of slippage of ligature, slippage of this suture. Your sorry has not worked. Now remember, reactionary hemorrhage is the most dangerous hemorrhage. This is life-threatening. Of course, the boyfriend will not give you one slap. He'll give you punches, kicks. If he's a big muscular man, then you are in a real trouble. If he's a thin, lean man, he will bring 3-4 friends with him and you are again in real trouble. So reactionary hemorrhage is the most dangerous hemorrhage. Okay, it can kill the patient. Now, how will you control this reactionary hemorrhage? Now, once again, you have to say sorry to the girl in front of the boyfriend. Okay, so now once again you have to take this patient to the operation theater and again you have to go and say sorry to this paratonsillar vein. I mean, you have to again put a ligature and this time the friendship band will not work. You have to put a Rakhi over there. Okay, you have to make her your sister, right? So now you have to reapply the suture, repeat ligation, have to be done nicely so that there should not be any more bleeding, right? Okay, now let's say the girl didn't have a boyfriend. Okay, now she tries to find out about you. So she's not happy with your proposal. She tries to find out about you. She does some research and she comes to know that you already have a girlfriend. Okay, you already have a girlfriend. So what will she do? She goes and informs your girlfriend. Now your girlfriend comes up to you and starts beating you. That's known as secondary hemorrhage. So of course all this commotion takes time. So you see it takes around 5 to 7 days. So secondary hemorrhage occurs in 5 to 7 days. Now who is causing the bleeding? The second girl. Okay, so similarly over here the secondary hemorrhage is because of secondary infection. Okay, and how will you get out of this situation? Yes, the boys, you should know how you will get out of this situation. To get out of this situation, you will have to take your own girlfriend to some nice date or bring her some good gift. All right. So no, a sorry will not work over here. A date, you have to spend some money. So similarly, there is a secondary infection. The patient has to spend money and the patient has to undergo treatment with IV antibiotics. Right? Okay, so patient has to undergo treatment with IV antibiotics to control the secondary infection. So that was your hemorrhage, the most common complication of tonsillectomy. Other than this, we have already discussed patient can also have pain in the ear. Now remember, the pain in the ear, it's a referred pain caused by injury to glossopharyngeal nerve. So I've discussed the diagram earlier itself, that the glossopharyngeal nerve, it lies lateral to the tonsillar fossa, lateral to the superior constrictor muscle, and if you damage this nerve during tonsillectomy, it can lead to referred pain in the ear. Right? Okay, so these were the complications of tonsillectomy. Now before I end this topic of tonsillectomy, there is something that we must all know, and that is coblation tonsillectomy. Okay, so what is this coblation tonsillectomy? Now to understand coblation tonsillectomy, let's have a brief review of methods of tonsillectomy. So tonsillectomy, classically it is done with cold steel instruments. Okay, cold steel instruments, that is known as dissection and snare method. Okay, dissection and snare method. Now the advantage of the cold steel instruments or the dissection and snare method is that the pain, especially the post-operative pain, because during surgery, intraoperative, patient is in anesthesia, so he does not feel anything, but the post-operative pain is minimum. Among all the different modalities, the pain is minimum in the cold steel. So this is like a gold standard for the post-operative pain. But the bleeding over here is one of the maximum seen in all the different modalities. Okay, so the bleeding is very much high, but the pain is minimum. Now to circumvent this problem, we do tonsillectomy with the help of electrocautery. Suppose you do tonsillectomy with the help of electrocautery. Now you will burn the bleeding points. Okay, now because you burn the bleeding point, there will be pain. So the pain in electrocautery is high. It is the highest among all the different types. But the bleeding is minimal. Okay, it is the least among all the different types. So it is like a gold standard for bleeding. The electrocautery method is the gold standard for bleeding, but for pain it is very, very high. Now we have something in between. This is the latest advancement known as coblation tonsillectomy. Now what is happening in coblation tonsillectomy? This method uses radiofrequency. And with the help of radiofrequency, it breaks the sodium chloride into sodium ions and chloride ions. Now the ionized sodium is then used to dissect the tissues. So the ionized sodium dissects the tissue in a bloodless plane. That means there is no bleeding, okay, as low as cautery. And now because you are going in a bloodless plane and the coagulation, there is no heat, so there is no post-operative pain also. So pain is as low as cold steel, the bleeding is as low as electrocautery. So this is one of the latest methods of doing tonsillectomy known as coblation tonsillectomy. Okay, so the only problem with the coblation tonsillectomy is number one, the cost, number two, the site heals over a little longer period, so it usually takes 4 to 6 weeks to heal, but this is one of the best methods for doing tonsillectomy nowadays. Okay, coblation tonsillectomy, there is bloodless and painless tonsillectomy, right? Okay, so that is your coblation tonsillectomy. Now, this question asked in JIPMER May 2018 exam, in peritonsillar abscess, that is quinsy, pain is referred to the ear by, we discuss it is the glossopharyngeal nerve, ninth cranial nerve. Okay, let's look at the next question. During acute tonsillitis, pain in the ear is due to effects of which nerve? Again, this question was asked in NEET Jan 18, same question repeated. Answer is glossopharyngeal nerve. Okay, next question. Let's go and see over here a syndrome before we finish the topic of oropharynx, that is known as styalgia or Eagle syndrome. Now let's look at this diagram first. Okay, now in this diagram we have the mastoid process. Just anterior to mastoid process you can see the styloid process. From the styloid process there arises a ligament. This is known as stylohyoid ligament, and it goes and attaches to the lesser cornu of hyoid bone. Okay, so that's known as stylohyoid, going from styloid to hyoid, stylohyoid ligament. Now, what is this Eagle syndrome? This Eagle syndrome or styalgia is that this stylohyoid ligament sometimes undergo ossification or calcification. As a result of that, this styloid process may become an elongated styloid process like this. And this elongated styloid process, it impinges on the glossopharyngeal nerve. Okay, so it impinges on the ninth cranial nerve, the glossopharyngeal nerve in the tonsillar fossa, and it causes pain in the throat. Okay, so it causes pain in throat. So patient will come to you with complaint of pain in throat, and that is because of an enlarged styloid process impinging on the glossopharyngeal nerve. So that is known as styalgia or Eagle syndrome. Okay, you can confirm this syndrome by this X-ray. In the X-ray you can see the enlarged styloid process. The treatment is removal of this styloid process, that is known as styloidectomy. Okay, so this is known as styloidectomy. To do styloidectomy, you have to go through the tonsillar fossa. That means first you have to do tonsillectomy. So this is another indication of tonsillectomy, not an absolute indication. We can also go through anterior tonsillar pillar also, but many people, they prefer to go through the tonsillar fossa. So they do tonsillectomy, and thereafter you can go laterally and you can do the styloid process removal, known as styloidectomy. Now remember that when you are doing styloidectomy, you can see over here, this is the ECA and this is the ICA. So just behind the styloid process, we have the ICA. So be very careful that when we are removing this styloid process, just behind the styloid process, we have the ICA. Okay, so you may damage the ICA. Have to be very, very careful while removing this styloid process. Okay, also remember that this ICA may form a aneurysm. Okay, so we have an IC aneurysm, okay, and it is just behind the styloid process. So this IC aneurysm may be there, and it may form a pulsatile mass in the tonsillar fossa. So sometimes you have a pulsatile mass, okay, so this is a pulsatile mass in the tonsillar fossa. So what can be the cause? The cause can be the ICA aneurysm, right? Do not try to do a tonsillectomy, do not probe it. First you have to do an imaging like an MRI or a contrast enhanced CT scan and confirm whether it is an ICA aneurysm. So a pulsatile mass in the tonsillar fossa is likely to be a ICA aneurysm because ICA is just lateral to this tonsillar fossa. Okay, we'll study more about it when we'll see the further diagrams. All right, so treatment for this styalgia or Eagle syndrome is styloidectomy, and that is done along with tonsillectomy. We first do tonsillectomy, then we go lateral and we do styloidectomy. There is another way you can go through the anterior tonsillar pillar also. So I have not considered styloidectomy as an absolute indication for tonsillectomy, but yes, it is done when most of the times when the surgeons, they do styloidectomy. Let's look at this question. Styalgia may present with ear pain. Which nerve may refer the pain? Once again, it is involving the ninth, the glossopharyngeal nerve in the lateral aspect of the tonsillar fossa. So that is our answer to this question.